Welcome to our webinar. It's entitled Headaches and Migraines Unnecessarily Complicated. This is Dr. Filner, and I'm visiting you from the Pain Center in Rockville, Maryland. We want your feedback, and during our presentation, please ask any questions in our live chat box, as well as give us any particular feedback, positive or critical. That's certainly during the webinar, but you can also do that after it by the website and email that we'll give you at the end of this. We want to continue to enhance your experience with your help. My experience in terms of treating pain problems, treating pain patients, is that I've been a board-certified anesthesiologist for 19 years. Contracting Meniere's disease forced me into another area of practice, and I've been doing this in a solo practice here in Rockville, Maryland for pain medicine for the past 23+ years. Initially, Dr. Janet Travell helped me get into this practice. I had met her several years earlier, and I had been attending her seminars, and she referred patients to me, and we had frequent meetings both to discuss clinical problems and to socialize. And I spoke with her at a number of seminars and meetings where she asked me to accompany her, mostly talking about the sympathetic nervous system and how it began to be involved with myofascial pain, and she was quite interested in that, and unfortunately she retired before we had a lot of information about that. For the first 15 years of my pain practice, I did more than 250,000 individual trigger point injections. As an anesthesiologist, I got quite facile at doing injections, and I did quite a few. Over the last 4 years, it has significantly decreased, and now there are only, I think, 4 patients in my practice who receive trigger point injections. All the rest are treated with the ML830 low-power laser, and I have probably, by this time, gotten to close to 120,000 trigger points individually inactivated with the ML830. This is the most important slide you're going to see today. When you treat chronic pain, you really need to think outside the box. Don't place patients right into a pigeonhole and do your diagnostic protocol based on that. You have to realize that trigger points in myofascial pain create things that we were taught 30 or 40 or 50 years ago could not happen, and they do happen. And part of what you'll learn from these series of webinars is exactly that they do happen, and that using the low-power laser is the perfect way to deal with these problems. Today's seminar, as I mentioned, is on headaches, and if you've read any of the literature on headaches and gone to any seminars conducted by so-called headache specialists, who are almost always neurologists, they are classified mostly by symptoms rather than causes. You see cluster headaches, you see tension headaches, you see muscle contraction headaches, you see frequently diagnosed is atypical migraine. Neurologists tend to very narrowly look at most headaches as if they're migraines, and if they don't fit the usual pattern, they call them atypical. So I'd rather get to the underlying problem and deal with the headaches. And if you really look at these patients and use your knowledge to palpate these trigger points, you can make a major contribution to either eliminating their patient's headaches or significantly reducing them. And one of the things I've learned over the past 23+ years is that every headache, just like most chronic pain problems, have some component of myofascial pain with trigger points. It may not be totally caused by myofascial pain, but there's some component, and you can clearly help the patient by inactivating those trigger points. When you have a patient where you see that you're the first one to see them, which is kind of unusual, you want to first rule out any physical or structural problem that either may need surgery or may need specific treatments, such as brain tumors, hypertension, stroke, AV malformations, aneurysms, etc., by taking the appropriate history, doing the appropriate physical exam, and any imaging tests. Assuming all of these are ruled out, and usually if you're the 5th or 6th or 8th doctor to see these patients, they have been ruled out, then you start looking for trigger points and inactivate them with the laser. And you will see many of these headaches begin to resolve. When you see these patients and they've had these other problems ruled out, you palpate for trigger points based on the patient's report of the location and character of the headache pain. Muscles usually involved are the upper trapezius. Anteriorly refers to the side of the head near the temporal area, and the posterior part of the upper trapezius refers to the back of the head and the upper neck. The temporalis muscles frequently will be reported by the patient as a feeling of a hose clamp being tightened around their head, or occasionally as feeling as though their head is going to explode. These are common descriptions of headaches that are generated by trigger points in the temporalis muscles. The splenius cervicis usually starts as neck pain and occasionally entraps the greater occipital and or the lesser occipital nerves, and can give you various types of pain and numbness and tingling depending on whether they entrap those nerves. The suboccipitals, and you have to remember to check all three of them, will frequently give you changes in visual. I think the best word for it is visual acuity or apparent visual acuity. Patients will say that their vision appears to be a little less clear than usual. They'll go to the ophthalmologist and find out that their refraction shows no change whatsoever. When you inactivate the trigger points, the patients will say, gee, my vision is clearer. They also refer to the side of the head, and they can sometimes give rise to the same symptoms that the temporalis trigger points will. The splenius capitis muscles will also give you pain at the top of the head at the capitis area, and often is reported as pain when brushing their hair or touching the hair. The semispinalis is often a problem in flexing the neck, and frequently is a core trigger point in the sense that once you inactivate that, the entire neck musculature really relaxes. So it's one of the ones you should probably do first. It occasionally refers to the forehead. And particularly, you'll find patients classified as having migraine often have this trigger point. And finally, the sternocleidomastoid, which sometimes refers to the anterior forehead on both sides, even though you may only have one sternocleidomastoid muscle involved. And additionally, will give the patient tinnitus and occasional dizziness and a feeling of fullness in their ear, and perhaps ear pain or difficulty swallowing. And don't forget, you may be treating a satellite or a secondary trigger point when you find them in the neck that is referring pain for headaches. And you may have to look further to palpate for the primary trigger points, which could be in the levator scapulae, the lower and the middle trapezius that refer into that area of the lower neck, and occasionally the posterior scalene muscle. As a review, which many of you may not need, but I think we should at least go through it for a moment or two, is that a myofascial trigger point is a hyperirritable spot, usually within a hardened or a taut band of skeletal muscle that is painful on precise compression. And that means if you move a half-inch away, the patient will say, "It doesn't hurt there." And that can give rise to characteristic referred pain, tenderness, and autonomic and other epiphenomena. They can be active, in which case the patient can say, "I hurt right there at the trigger point." If they're latent, which is usually the next stage before they begin to go away, the patient won't tell you that they hurt at the specific trigger point, but the muscle is tight, and they may report referred pain or other of these epiphenomena. They can be primary, meaning a core trigger point, secondary arising in the reference zones, or satellite trigger points that arise because a change in the function of the involved functional unit. When you palpate the trigger point, you frequently get a twitch response. If the muscle is very tight, you won't see it, but normal muscle will not respond that way at any time. The myofascial trigger point characteristic is that, and this has actually been published, that a muscle is electrically silent at rest, meaning at best the muscle is a little bit tight but can be apparently not significantly functional, and is certainly reported as no spasms. The trigger point can be electrically active. If you put an insulated needle into the muscle, the tip will record the EMG, and that muscle will be electrically silent when it's at rest. And when you put the needle into the trigger point, you see significant activity. Dr. Simons has postulated a theory as to how the trigger points become present, in that after an injury, the zone of dysfunctional end plates occurs, and the end plates are where the nerve enters the muscle, and that this results in a mini contracture, which is palpated as a taut band, and which uses an excess amount of energy, which then this taut band causes a decrease in circulation, and the need for increased energy is not satisfied, and you see an alphabet soup of compounds, CGRP, substance P, etc., which is now released and sensitizes the small C fibers that are nearby, and you are aware of pain at that site. And again, this is a theory. One of the concerns is whether or not the release of these compounds is a result of the localized tenderness, or is the cause of the pain and sensitivity. That has not been totally established at this point. And you should always remember that tightness does not equal spasm, and if you see a report that says there's no spasm in any of the muscles, that doesn't mean there's no tightness and that there are no trigger points. It just means that the individual writing the report doesn't really understand what the muscles will be like when the trigger points are active. Excuse me. Locating a trigger point either by